So, good evening to all. Good evening to the senior faculty, the leaders in anesthesiology in India, within the panel, and those who are in the audience side also. A special welcome to the budding anesthesiologists who are very much enthusiastic to come over here to speak their mind on anesthesia education or the current anesthesia training from postgraduates perspective. We are trying to identify the good performers among the postgraduate panelists, and we will be appreciating them with a certificate of appreciation from the Indian College of Anesthesiology. In this program, I am joined by Dr. Aravind Narayanan, who is a consultant in Chennai, who had been my colleague during my tenure in Sultan Qaboos University, Muscat. Welcome, Dr. Aravind.
Thank you. Good evening.
So in this program, we got postgraduate panelists from across India and one panelist from outside India also, from United States, to give us some perspective from United States anesthesia training point of view. So we'll introduce all the postgraduate panelists. I'd like to the postgraduate panelists to introduce yourself with your name and course and the city you are coming from. Dr. Ramya Chitra.
Good evening, sir.
Yes.
And good evening, respected all the faculty over here. Myself, Dr. Ramya Chitra. I'm doing my final year post-graduation, MD, from the city of Srikakulam. Thank you.
Okay. We'll listen to you during our discussion. Dr. Shanmuga Priya, please.
Good evening, everyone. I'm a final year postgraduate from Pondicherry.
Okay. Yeah, you are undergoing MD program, right? Dr. Pratik.
Hello. Good evening, everyone. I am Dr. Pratik, and I'm very honored to be present here in this August Assembly. I have completed my post-graduation in May of 2022, just a few months back, and I have just joined as a senior resident in Chandigarh. So I'm here.
Great to have you here. Okay. Dr. Janish.
Good evening, sir. I'm honored to be a part of the panelists. I'm doing my final year post-graduation in the anesthesia. I'm from Malappuram.
Okay. Dr. Aditya Gopal Sharma.
Good evening, everyone. I'm Dr. Aditya Gopal Sharma. I'm doing my final year MD at Belagavi, Karnataka.
Okay. Dr. Durga.
A very good evening to all of you, respected sirs and ma'am. I'm Dr. Durga Dilip. I'm a first year DNB resident, anesthesiology from Trivandrum.
Welcome. Dr. Arshid. Hello.
Good evening. Hello.
Yeah, please. Yes.
Yeah. Good evening, faculty members and dear colleagues. I am Dr. Arshid, MD final year from Jammu.
Okay. Dr. Neetu.
Good evening, teachers. I'm very honored to be in this session with all the eminent teachers. I'm a first year MD resident from Kerala.
Okay. Dr. Vinod. Dr. Vinod, can you unmute and introduce yourself? Okay, we'll come to you during the discussion part. Okay. So actually, we have done an online survey among the postgraduates undergoing anesthesia training across the India and maybe overseas also. We have got a survey report to deliberate on. This is what the budding anesthesiologists, the upcoming stalwarts probably in the coming years will prove that this is what at this point of their career or this point of their training, they think about the specialty of anesthesia. This word cloud will tell you all there are different views, different perspective. A few things are common, like life-saving skills. It's challenging. It requires leadership. So we'll come to that one by one. And we have leaders in anesthesiology joining with seniors perspective towards the latter half of our program coming with their thoughts on the practicalities or how they feel about the problems and solutions put forward by the budding anesthesiologists. Now, to the audience, you are also not left out. Like, if you want to join the discussion, you are also welcome. So how you can do is, if you have a point to raise or an agenda, discussion agenda, kindly text in the chat in the Zoom meeting with your name and institution affiliation. During the interactive session, we'll try to accommodate your views as well, because it's a forum for everybody to put their thoughts on how to improve the training system in our place. Okay, right. So I would like to bring one more option. Audience, from the audience, postgraduates, you can take your mobile phone and take a browser, go to www.menti.com, menti.com, and enter the code 42135945 and join the survey. Meanwhile, we are just starting with our deliberations. So the code is 42135945. I'll put it in the chat. Now I request Dr. Aravind to start the PG panel discussion, invoking their perspective. Over to Dr. Aravind.
Very good evening. Nice to get started. And yeah, the next few minutes, maybe 20-25 minutes, we'll be spending in eliciting or teasing out, as we say in dissection. We try to tease out the perspectives from our postgraduates who have joined us from different parts of India. Yeah, so let's get started with Dr. Shanmuga Priya. So welcome all of you. Dr. Shanmuga Priya, you can, and other panelists, please, you can unmute yourself as and when you want to speak up, and you can also raise your hands in order to make a point or a counterpoint. Yes, Dr. Shanmuga Priya, shall we first hear from you? Ladies first.
Yes, sir. Okay, this is a program which is very new to me, actually, something which is going to build the academic strength among our colleagues. So this is something which we are all looking forward. And this program is going to help us to know more about our own career itself, about anesthesia is really a beautiful branch. So many people are unaware of what are all the scopes of anesthesia, what are all the actual points which we can gain from anesthesia. So this program is something which is going to help us to know more about our own department, our own specialty, know more about what are all the academic problems which we are going to face, and certain solutions which we are postgraduates from our point of view, maybe we can raise our problems. And so many experts are here in this area, so that if we can raise our doubts, we can get the answers from experts and super specialists' opinion also. So thank you very much for inviting me for this session also, sir.
Yeah, a number of you all are from the third year of post-graduation. So once you've already traveled 3 years, what do you feel, Dr. Janish? Are you enjoying the journey?
Yes, sir. I mean, when I got into my anesthesia, got into my PG course, I didn't have much of an idea like what I'm getting into. And I think in the first like few months, I was actually, there was in total darkness. But now I think I have a good picture of that, of what I am doing, what is my actual role. Not just as an anesthesiologist, I know what is expected from me, and what I have to do to my patients. I mean, they are absolutely risking their life, when they are coming to me. So I'm happy that I took a good course, and I'm looking forward to it, sir.
Very good. Dr. Durga, now I guess you're the first year?
Yes, sir.
Okay, so now do you subscribe to Dr. Janish's point of view that in 2 years he has understood quite a bit of what anesthesia has got to offer?
Yes, sir. I'm hoping as well that in the coming months or maybe in the next year, I'll have a much clearer idea of what it is. But my point of view from what it was when I started or joined for this course has significantly changed. I was like very confused in the beginning about what exactly I'm supposed to expect. But over the months that I've just been in this field for a few months, but over those months, I've really grown to like the subject, and every day I'm discovering something new. And that's what I think is very special about our subject. And I'm looking forward to developing more of my skills as well as my interest in this field.
Okay, thank you, Dr. Durga.
Thank you.
Dr. Prateek, I think he has just crossed the 3-year PG training program.
Yes,
So
sir.
now you have a fresher telling you that she's seeing a new facet of anesthesia every day. What do you feel about it? Have you
And
seen all
that
of
is
it
the
in the
good
3
thing.
years?
Yeah, that is the great thing about it. Every day you learn something new. I think it's really heartwarming for me as well, because when I joined, I remember that I used to get very overwhelmed. There were a lot of alarms, there was a lot of chaos going around. And in MBBS, I don't think we're that much exposed to this field. But gradually over these 3 years, when I have passed, I can now look at the juniors who have just joined. And I always tell them that you will get used to it, because we always doubt whether we will be able to do what we are seeing, because all these procedures, then all these alarms going on, it's always a lot of things going on all at once. So the art of getting into it, that is what fills me with I pride myself as a very proud anesthetist, and that has evolved over all these 3 years, and every day there's something new. So I love my branch completely.
That's nice, and that's from a professional who is just starting his professional journey in anesthetics. Coming back to this, the points highlighted here, Dr. Aditya, what do you feel that is the first few months in anesthetics training different from maybe training in surgery or internal medicine or obstetrics? Do you think this is a different specialty? It's a different cup of tea?
So what I feel is that anesthesia is actually underexposed to the UGs are underexposed to anesthesia in their UD life. So MBBS does not give importance to anesthesiology. So when they come into the PG life, when they come as first years, it's a totally blank subject for them. Everything is new for them. Surgery and OBG, they've seen, they've gone to labor rooms, they've gone to the OTs, they've been suturing and all. But when coming to anesthesia, that it's totally new. They've never been in the OT. They've never experienced the stress levels an anesthesiologist has in the OT. They never know how to manage the case like that. So what I feel is that more importance should be given in the MBBS curriculum, so that when they come as first years, they'll have a better idea about anesthesiology.
Thank you. Thanks for the points. Anybody wants to add to this?
Yeah, requesting the panelists to raise your hands if you have something to add on to it. Dr. Neetu, please.
Yes, sir. Definitely, I agree to what Dr. Aditya was saying. During UG days, we were very limitedly exposed to anesthesia, and we were whatever exposure we got was only spinal and just intubating the patient. So now we are getting to know more about what anesthesia is more about. It's not just confined to giving spinals and just intubating the patient. We are walking on a tightrope, maybe in the OT, because not letting things go too far, not letting things come down to the lower this thing, like we walk on a tightrope with our patients when they are entrusting us with their lives.
Exactly, that's the problem part of it. Can we think about a solution for that, Dr. Ramya? Dr. Ramya Chitra? Yeah, you can unmute and talk. Yeah, mic is in mute mode.
Sorry, sir. Yes, as most of my colleagues have addressed that during the internship we are exposed less. Mainly what differs from other branches to our branches is we should learn the art of keeping the coolness during the chaos, sir. So this should be the main part in our specialization, and we also need to have a greater perspective in each and every field. Like we need to, as per the radiologists, as according to the physician, and we need to take a decision soon. So this thing, most of our colleagues or most of us won't be having an idea during our internship days, sir.
Okay.
And Dr. Rachna is around. Could Dr. Rachna come in and let us know your thoughts about the teamwork, about us interacting with so many other specialties which Dr. Ramya Chitra just mentioned now. You need to unmute yourself, please, Dr. Rachna.
I think there is some.
I don't think she's audible to any of us.
Yes.
You're not audible to us. Sorry.
Unmute.
Go ahead.
Yes.
Am I audible?
Yes. Yes.
Speak a little louder, please. You should speak.
Yeah. Hello. Good evening, everybody. I'm Dr. Rachna, MD in Anesthesiology. Actually, as well pointed by the rest of the speakers, it's quite an overwhelming situation, and also a platform in which we get to discuss about the issues and also the solution with the expert panel. Very much grateful, and I'm thankful. Regarding the PG anesthesia training program here itself, I would like to say that we get whatever exposure that we have gotten in intern days. It's like very minute of what we actually experience and go through during our residency years. I would like to say interaction with various of the departments, starting from clinical branches, non-clinical branches, paraclinical branches. It's quite a one should have a leadership qualities, I would say, to interact with and have a command over the situation, and also interaction with the other doctors, the attendants, the patients should be there for all of us, and we should inculcate in among ourselves during all these 3 years of training, which would help us in the further journey of our residency and graduate, I would like to say. And also there is much of accordingly, we definitely day to day we deal with surgery, we deal with orthopedics, we deal with super specialty, we deal with pain clinic, we deal with critical care, we deal with organ donation, brain dead. There are very much different branches and spectrums which are looking to us. It's a challenging and also an overwhelming situation, but definitely we do have our seniors and faculties to guide us in this and give us the guiding path, guiding light to go through it.
Okay, thank you, Dr. Rachna. So just quickly summarizing, most of you have expressed that it's quite an overwhelming first few months. Isn't it true with other specialties too, or is it something which is specific to anesthetics? And I think to extrapolate, do you all feel that you're unprepared in the first few months, or you're unaware about what are the things in store for you in anesthesia? And would this need to be addressed earlier on, either during your training or during internship? What do you feel about this? Anybody wants to? Dr. Anmol, please, could you come in?
So in the first few months, we feel overwhelming while we are posted during our duties. So what I feel is it is because we are unaware of what we are going to face in the anesthesia residency. So I think there should be a workshop or something during the internship period where we get an exposure that what all we are expected to do when we walk into the anesthesia residency. So like we are skilled resuscitators. So programs like the BLS course or the ACLS course, it should be mandatory during the internship or during the undergraduation period. So.
Okay, so just quickly summarizing, can you hear me? Can all of you hear me?
Yes, yes.
Yes.
Yeah, quickly summarizing, the acute care nature of the anesthetics program is what overwhelms all of you. Is that what is right? Dr. Arshad, would you come in at this point and give your views whether we need to have any kind of a primer or a requirement for working in anesthetics before joining the PG program, so that all of you can make up your mind? Is that something, would you feel anything, any perspective on?
Yes, sir. I would like to add on that during internship, there should be a lot of exposure. Like, we don't involve interns today, active patient care in anesthesia internship. As the intern comes and sits in the OT. We can do one thing, we can involve the intern in the patient care, explain the procedure, explain how we induce, how we do extubation, so that he get sensitized to the anesthesia. As an intern, I don't remember what I have done as an intern in anesthesia. It was the one incident when the patient had a cardiac arrest. The anesthesiologist came, started CPR, started doing multiple tasks together. That day, I decided that I want to be the anesthesiologist because there was that adrenaline rush was there. Otherwise, I don't remember the 15 days posting. I did anything in the anesthesia apart from when I was involved in the patient care. That day, decide I want to be an anesthesiologist. So I think there should be an exposure.
Very nice. That's very nice, and it's a very nice anecdote for a snippet from Dr. Arshid. And we need motivating moments like this.
Yeah,
Go on, Dr. Arshid.
Yes, sir. So I think we should motivate interns to join anesthesia as PG. So
Dr. Nitu, could you come in now? Do you feel allowing interns to be a part of the care of anesthetics, is it going to compromise safety of the patients? Is that something which is...
I definitely feel we should be like as interns, we should have more. We should be interested with a little more of role in practicing anesthesia, because we are always under the guidance of someone. We are always we are not. It's not an individual thing. We are always guided by someone. So taking part in the whole that whole orchestration in anesthesia, it's something that we all need to get exposed to as interns also. Because when I joined anesthesia, the most overwhelming part for me was there are too many circuits, there are too many machine things, drugs are all new to me that I have not been using so far, all those IV agents and all. So it's like a new whole thing to me that I got into. But as interns, I think we should be a little more into all these parts of managing the circuits, at least using the vein circuits and all those. Accompanying the patient and doing the basic things in anesthesia, or at least loading drugs and all under guidance of someone.
Okay, so at this point, would somebody would like to differ with what is being said? Why should an intern be taught everything about anesthesia when he or she is going to become a dermatologist or a biochemist or a microbiologist? So will there be an information overload, and also the resources might be wrongly deployed in training somebody who's not interested in anesthetics? So Aditya, would you like to come in?
Yes, sir. I think that as an anesthetist, we learn a little. We have a finger in every pie. We deal with ventilators. We deal with some drugs which other people do not deal with. So I don't think it is necessary to overemphasize anesthesia training in internship per se. You can learn small parts of it, which is how to run a ventilator, how to check a circuit for leaks, rather than have an intensive course on how to conduct a surgery that may not be of interest to a person who's choosing a non-surgical branch.
Fair point. I guess with the COVID epidemic, we saw that a lot of acute care and respiratory care was expected to be known by a lot of doctors, irrespective of whether they're anesthesiologists or not. So maybe in that context, acute care and maybe life support, trauma life support, and things like that could be a part of the internship. But we need a mechanism to motivate more interns to know more about our field so that it's not overwhelming. So Dr. Ramya, would you like to come in and say something apart from training the interns, apart from giving them something, is there something else which can be done to motivate them to join? Do you think we should tell them about what all anesthetics has in offer as a spectrum of subspecialties?
Definitely, they should have a good idea, sir, because not only as a part of anesthesia curriculum, even if one of their relatives or one of the family members is posted for something surgery, they should have a better idea on how to optimize and what about the risk will be there. They should have a idea about that, sir. So in that field, being an intern, they should be able to tell to the family member or the relative who is posted for a surgery or so. They must have an idea, or the risk related in terms of hypertension or diabetes. What is the risk? They must be able to assess things.
So now I think we have understood that being an intern, we need some inputs. Now let's move on to the first and the second year of anesthetics. We move on down the line, down the journey. So the first year and the second year, the amount of caseload, amount of work expected of you, do you think there's something different which needs to be done about it? Dr. Shanmugapriya, as a first year, do you think we should be given less work or more work?
Actually, in generally as a postgraduate, not only in this department, every department, it is considered like a fact that first years will be overburdened by most of the works given by seniors or so on. But it is not that we are only overburdened. It is like we learn, though we are overburdened, it is in that place where we learn, doing some small stuff. Each and everyone can make so many mistakes in that. Once when I do 100, once when I see 100 to 200 patients, that is the reason time when I come to know that I can see a patient effectively in 5 minutes. Everyone can make mistake, but unless and until we are exposed to certain situations where we are doing so much works, we will not learn. Unless and until we may scold people that they are leaving us alone, we don't know anything, how we'll manage alone. But unless and until we are left alone in certain situations, we won't think. We need some stimulating factors which help us to think, which help us to work. So that is something which has to be done. Maybe the works can be shared by seniors in an encouraging or supportive way. That will be something very good for each and will motivate us to work more, think more, ask questions. So asking questions, some might not like, some might like. So encouraging people to ask more questions is something which each and everyone needs to develop that things. So that we develop more interest towards the subject.
Okay, so continuing the same line of thought, Dr. Pratik, when Dr. Shanmugapriya says seniors, so when you say seniors, is it first, second, and third year PGs who always work as a team, or do you always have the faculty around with you, or do you think the faculty should be more involved in the work which you're doing on a regular basis?
Sir, I completely agree with her on this point that the juniors need to be taught well and they should be allowed to work as well. And especially in teaching hospitals, that the juniors should work and they should be allowed to work under supervision. Because when you're giving the juniors the opportunity to just stand and observe in their early times, you cannot expect them that when they'll turn second years or third years, then they'll be proficient with the work. Secondly, there are certain things like using a fiber optic or using a bronchoscope, that those things need to be taught, but under supervision. That's what I believe in. And when we're talking about these formative ages, I think we're focusing on internship, but we're forgetting about the UG course as well. Because during MBBS, we used to get posted in anesthesia. We used to have a posting, but I don't remember if we even attended that posting. So I think if those MBBS students are allowed to come in the OT and allowed to see instead of just the scut work, then I think that will be more benefiting.
All right, fair point. So the juniors need to be given more workload in terms of doing things on their own. Is that what is the perception? Fine. So what do you think, should we compartmentalize the 3-year teaching program into first year you should do these, second year you should do these, third year you should do these? Is it possible to run the program like that? Or do you think there should be an overlap of everything and a gradual autonomy, increasing autonomy given to you as you go from first year to third year?
I think at any given time, there's not like first year, second year, third year, and start. They're not posted simultaneously together. It's not necessary that all these people will be posted. So at any time, the roles may vary between the senior and the junior.
Hello.
Hello, I think there is some audio disturbance. Okay, let's quickly go across to Dr. Asad. Are you here with us to tell us about the curriculum that he is exposed to?
Yeah, so thank you for having me. I'm Dr. Asad. I'm at the University of Iowa as a resident. I'm in my third year of residency here. So I have one more year after this year. So in terms of how things are here, I mean, it sounds, based on kind of everyone's experiences, it sounds similar in many ways. I think, so obviously as a medical student here in the US, it's a lot of just getting exposure to kind of every different specialty. Anesthesia in general is not the most is not something that everyone sees. Sometimes people will do elective rotations as medical students and they'll have a chance to be in the OR, but they don't have very much hands-on experience. They may get to do some intubations and place IVs, but that's usually the extent of it. So that's kind of one of the barriers, I think, in terms of getting people to do anesthesia, is because they don't have a lot of exposure early on as medical students. Once they decide to do anesthesia based on, for whatever reason, once you get to residency, your first year you do internship, which is essentially everything except for anesthesiology. At the University of Iowa, they do a good job in terms of making rotations that are relevant to anesthesiology. So you'll do a few months in the ICU, so that will inevitably have some good translation to anesthesia. They have internal medicine and then some subspecialties along those lines as well. So there's a lot of things that you do, all of which are relevant to anesthesia, but it also depends on where you go. Other programs, their internship will be purely internal medicine for 12 months. So you may do some things that may be helpful and other things that might not be as helpful. But then once you get into the operating room, I think everyone's kind of talked about it and described it the same way I kind of look at it. At the beginning, the tough part is really learning to become a technician. You know, there's that technical part that is a huge learning curve that everyone has to kind of figure out and spend time to get competent with, in terms of just placing IVs, intubation, and then just understanding the overall workflow. And then once I feel like you get to that point and become more comfortable, then you can really spend the time actually thinking and doing the things in terms of like coming up with anesthetic plans and doing the more intellectual side of the job. So it is difficult, I think, sometimes, because the initial learning curve up front is very difficult to kind of overcome before you get to take that next step to making the plan, which in general is the thing that will be the most important.
Thank you, Dr. Asad, for joining in. It was nice to hear certain aspects, and I guess, as you pointed it out rightly, the initial technical part or the workflow is something which we need to know. And this is, I think, quite a challenge for any of the first year postgraduates in any specialty. And then by and by they get used to it. But yes, by the second and the third year, we expect that planning, team management, and leadership and things like that come in. So why do you think anesthesia is it something different? No, I think team management works here also. But Aditya, what do you feel? Did you learn team management once you're a postgraduate in the first year, or did you learn it at the second or third year? Or do you think it's important to learn it at any point?
Sir, as anesthesiologist, along with the technical skills, we also need some non-technical skills, which includes team management, leadership skills, communication skills, and all such skills which are vital in patient safety and management of a patient. So such skills, they develop over the time, sir. In the first year, it is difficult to get all the skills because you'll be busy with learning how to give a spinal, how to intubate the patient. But once you come into the second year, you'll slowly you will know how the patient, you'll anticipate the events, you'll come to know how to manage the patients. Then you'll be part of the team and you will start working along with the seniors and the senior residents, and you'll be able to take care of the patient in a better way. So I believe in the second year is a time when you start developing all these non-technical skills.
And what happens when you come to the final year? You're given the task of independently doing things, though under observation, but is that not overwhelming too?
The final year PG is, I believe, is the time when the leadership qualities develop. He's expected to be individual and he's expected to supervise over the juniors. So that is the time when you're individual and you'll be able to start working individually and take care of all the patients, supervising the juniors also.
Okay, Dr. Shanmugapriya, at this point, do you feel that the final year is also quite overwhelming because you're learning lots of things in independent management? At the same time, you're also expected to read for your exams and prepare your dissertation and complete your logbook and do the subspecialty rotations and so on.
Yes, sir. Actually, it is like a balance thing. We have to learn to balance everything. But unless and until we are left alone in final year to decide, I will not have the confidence to do it alone when I go outside somewhere. Because these are the 3 years where we have our seniors or SRs or whoever it is. We have any doubts, we have anything. Once we are left alone and we think, that is where we know that this is a problem where I'm going to face an issue. So I don't know how to approach this. I'll be having my senior just beside me so that I can ask. It is not that I'm completely left unobserved. Definitely my senior is going to supervise me. So once when I have reach a point where I'm not able to think further, where I'm not able to get an alternate ideas, I have someone expert to ask and clarify. That can be done only in final year. Second year, maybe I'm too immature. First year, I don't know anything. I tend to make a lot of mistakes. But as I mature each month, each year, as I learn new things, and once I know that next year I'm going to work as an individual one, I'll have more responsibilities. I'll start thinking whatever I'm doing, so I'm responsible for this job. If something goes wrong, means I definitely need expert. So if an expert comes and saying this management,
I just want to get back your focus on to the question which I had. Are there too many things to handle in final year?
Yes, sir, definitely. But it is essential thing which has to be handled, sir. Unless and until we are left alone, we will not learn. So it is an essential component and it has to be handled, sir. Maybe we can think of some measures.
Not to leave you alone, I'm sure the seniors will talk to you later about it. We don't want you to believe we are going to be helping you. But what I meant is in terms of what all the expectations from the final year postgraduate. Let's not forget that the MD anesthesia program doesn't incorporate the subspecialties. So what happens when you get a very complicated case in the final year? Are you geared up to handle it, or do you think that you need some help at that point of time? Can somebody else come in? If Dr. Rachana maybe? Is Dr. Rachana around?
Yes, sir. Audible?
Yeah. I think there are audio issues even with some of us. So please kindly bear with that.
Shall we take response from Dr. Ramya Chitra?
Yeah, let's go ahead. Basically, the question is the final year, are there too many things to be tasked?
Yes, sir. In the final year, we are having, as you said, sir, the thesis, the logbooks. Shall I continue, sir?
Sorry, Dr. Rachana, we're not hearing you well. We'll come back to you later. Let Dr. Ramya go ahead with her.
Yes, sir. As you told, there are many things, sir. That is the thesis, the logbooks, and the subspecializations, as you mentioned. But it is better we plan accordingly, sir. As we talk to the seniors, like logbooks, whenever we are doing the cases, it is better to write whenever, daily to daily basis. If we complete, it won't be much of a burden, sir. And whatever the special procedures we are doing, whenever we come across a case, it is better to mention then and there in the logbook so that it won't be a hectic at the end. And next, coming to the thesis also, in the first year, mostly the thesis will be having a view about what to do and what not to do. But the complications and whatever we're doing, we'll have a better idea as we go on to the second and third year. So during the end of the second year, if we do much of the cases, whether it is a post-op epidural or whether it is a tab block, whatever it is, if we do and note down our things, it will be a better easy, and the information that we collected, we can easily kept in an Excel sheet or in a hard copy at the end, so that it won't be a burden. And next, coming to the subspecialization, it is very essential, sir, as any complicated case we need to handle, we should have a better idea about it. And a rotation of in every subspecialty is necessary to have an approach, and also the other alternative plan, what to think, whether the patient might land up in bleeding, what to do then, what kind of plan B I'm having. So these most of the complications and most of the plan B or plan C will be mostly coming across in the subspecialty or in the super specialty things, like in urology, in CTBS, we'll be handling more complications than in the elective cases. I mean, like minor procedures like hernia or so. Yes, sir.
Okay.
I think
Dr.
we'll
Asad,
hear from,
sorry?
Yeah, I think
Dr.
we'll
Sanish,
hear from Dr. Anita Malik on the proposed modular teaching in anesthesia during the later part of the program. Yeah, Aravind, please go ahead.
Yeah, Dr. Asad, if you are with us, basically what happens in the US, when do you gravitate to channelizing when about the subspecialty you plan to do after your anesthetics?
So really the way it ends up working, so again, so much of this is dependent on the residency program and how it's set up, but I would say in general, you will have once you're in the operating room and doing anesthesia as your primary like training, you will have subspecialty rotations. So you'll spend a month doing cardiac, you'll spend a month doing OB and pediatrics, acute pain. When you get the opportunity to do those can sometimes vary, and that'll oftentimes vary based on the program you're at. But it's kind of a process that you have to make somewhat early. I will start applying for fellowship by the end of this year, so in December. So I still have a whole another year left of training, but I already have to kind of make a decision on what I want to do. So that is kind of the challenging part, is you have to have some amount of exposure to know what you're getting yourself into before kind of signing up.
Okay, so to summarize, Dr. Asad, by the end of the second year, you need to have exposed yourself to all the possible roadmaps ahead, and then crystallize your thoughts and then start application. So I guess it's a 3-year residency program even in the States.
Yes, so it's 3 years with a required internship, which is your first, so 1 year plus 3, so a total of 4.
All right, so given this, Arshid, what do you feel? That would you have made your choices by the end of your second year and then start working on the subspecialty work, and what kind of guidance do you think is needed? So we are looking at a sort of a cycle. At the end of internship, we are now looking at what are the possible specialties we would take in, and at the end of the second year of your actual MD anesthesiology, you are now again saddled with the same set of questions. So how do you hope to encounter them?
As a final year MD, I have more responsibility than my juniors, and I have to sit and monitor the patient. I cannot leave OT and leave junior to monitor the patient. So as a final year, I have more responsibility to take care of my patient, and I am more experienced than my junior. And usually what we do, we let the juniors to do the procedures to expose them under supervision. So, and what else we do? And we take our juniors to the ICU. We attach them. We don't leave them independent in the ICU in the first 6 months of the training. This is how we sensitize our juniors to the specialty. Everything what we do under supervision. As a third year, I monitor patient myself. I let also junior to do, but I keep supervision whether he is monitoring the patient throughout the procedure, whether he's taking care of the blood loss, whether he's taking care of the ETCO2 other alarms. So this is how we do.
Good. But now that you're in final year, have you made your decision that you want to become a general practitioner in anesthetics, or do you want to become subspecialty like a cardiac, a neuro, or a pediatric? Do you think that's important at this point of your career, that you need to definitely do a subspecialization, or do you think doing an MD anesthetics program is a reasonably good option?
Yeah, actually, the anesthesia is the evolving branch. So now there is pain. I want to do a fellowship in pain medicine, so that I can be independent later on. So I can start up my small clinic and start pain clinic.
Oh, that's an interesting point. Being independent and being interdependent. So working in a team and not working in a team, working alone. So there are two different facets to this. What do you feel, Dr. Durga? You're in the first year, so you're now hearing different ways, concepts that by second year you need to decide, by third year you need to be more responsible, and the first year is anyway overwhelming. So what are your thoughts now on that?
Sir, I kind of agree to the point that responsibilities given to the residents should be not very much, but kind of graded, because since we are new when we are coming in the beginning, the basic opportunities are to be given. They make sure that the basic, like securing an IV line, the intubation, spinal, these are the basic procedures that we have to be taught. And slowly, as in not slowly, but according to how each resident is responding or how they are developing their skill, more, the seniors and the faculty together can decide that and give more opportunities, like more advanced procedures or exposure. And about deciding a specialty, I think yes, it is best if from the first year itself they are given information as to there are prospective opportunities even after completing the 3-year residency in anesthesia. Like if it's good, because if they are given exposure in moderate amounts, they can maybe they can develop an interest towards which maybe if they have to specialize, or like critical care or cardiac, or if
So
or maybe
are you aware of all the possible subspecialties in anesthetics now that you're in first year?
Yeah, I kind of asked around, sir, and that's how I got to know, because when joining anesthesia, I really did not know. I did not know what were the subspecialties, but I found it like really fascinating that there are so many possibilities, and I was kind of glad to know that. I haven't yet decided. Personally, I haven't decided, but I feel that exposure is absolutely necessary starting from first year itself, because it will really help them orient their future.
Dr.
One more thing
Pratik,
I
at
would
this
like to
point,
raise.
yeah, sorry.
One more point I would like to
Yeah.
raise for discussion. A few weeks back, we had a webinar session in our ICA platform where we discussed about the role of mentorship, mentor-mentee relationship, how the mentorship program inculcates an interest in a particular subspecialty. Is it really possible? Is there any scope for introducing a kind of mentorship program during your 3-year training period? Obviously, the mentee should be selecting the mentor. Suppose you choose intensivist as your mentor, you tend to go towards critical care. But how effectively the mentorship concept is working in our current education system? Any opinion from our panelists? Did you get my point?
So there's
Yes, because this is an overwhelming specialty, too many options around. But along the course of training, you tend to follow somebody. Like there should be somebody who you should be looking up to, who is very good in say cardiac anesthesia or things like that, intensive care. Somebody who is passionate about pain and palliative care, who is likely to draw you into that subspecialty. Dr. Pratik, your thoughts on that?
But I think assigning a mentor or making the PG choose a mentor, it will rather narrow down their options. I think why not choose it personally? You can have more than one mentors. You can be interested in critical care as well as in pain, as well as in cardiac. So why make it official and narrow it down? That's what I think.
It's a personal choice. Right. And Dr. Aditya?
What I feel is that instead of a mentorship program, it is better we work in a city, we work in a department, so we work in cardiac anesthesia, we work in the ICUs. Only then we'll come to know that if that specialty is suitable for us. Because even after MD anesthesiology, after completing the course, it is better to work and try out all these subspecialties. Work in the ICUs, work for some 6 months, get to know the things. Only then choose that as your specialty in the future.
You should also learn to know how life looks like for a consultant in ICU, consultant who has taken up cardiac anesthesia, neuroanesthesia.
Yes, sir. That's yes, sir.
Dr. Neetu, your thoughts on that?
Yes, sir. I also feel like we should taste everything a little. Like we should get the taste of everything a little to know what suits us better. So getting exposed to all the different specialties help us choose what we can do and what we can excel better in.
Okay. Suppose the institution where you are getting trained, it's a general statement. You don't have much of cardiac cases happening or much of the hi-fi gadgets. being used inside the OT. Would you suggest to have a tie-up program with some other institution for a definite period of time, maybe 1 month, 3 months, something like that, so that your whole curriculum as designed by the Medical Council or National Board of Examinations prescribed, so that it will be fulfilled? Is it possible, Dr. Ramya?
Yes, sir. By the end of, I mean, like even in the last 6 months of second year or in the initial 6 months of third year, it is where these subspecialties were limited. We can be assigned to near hospital or so where these subspecialties like the cardiac cases or the oncosurgeries or these cases will be going on, so that we will so that a 1 month posting or so that we will be having an idea the duration of the surgeries and the complications that which are anticipated and so on. It is better. So
And you will get used to the infrastructure also.
Yes,
Say
sir,
like
the
PA
infrastructure
monitoring,
and what all
monitoring.
things we need to be kept ready. For example, it varies with the cardiac case where we need to keep ready a lot of FFPs, platelets and blood, even in the oncosurgeries too, where the duration will be more and so on. So we'll be having a pre-for idea what investigations or what are the things that we need to keep ready for a subspecialization for a proper, for example, a cardiac case or a urology case that we need to assigned or seen. So that
will that be a way towards a uniform curriculum throughout the country, so that all the MD graduates or DNB graduates will be trained in a similar fashion?
Yes, sir. It is my
Required
opinion is
or,
that definitely there should be an like exposure to subspecialties, sir. Whether if it is limited in a particular institute, we should be exposed by having a posting or so, so that after the post graduation, it will also imbibe the field that we are interested in. Like for example, in cardiac or in onco anesthesiologist or so forth. It will also imbibe the field of anesthesia that we want to choose, the subspecialization. And also if we come across a case after post-graduation that we need to encounter, we will be ready with all the infrastructure and all the plan B actions and so on, sir.
So basically, we're hinting upon the non-homogeneity of training and clinical workload across different institutions. Is that something all of you concur on, or is that you feel that the cases will be more or less the same, which is quite unlikely? Sanish, we are coming to the 8 p.m. margin. You want to?
So I have something to say about what we just discussed now. Just like talking about the subspecialties, we should also be talking about the basic facilities that we might go into when going into rural practice. We might not get all those or at least the workstations also we might not be able to get an access to. So we should also be able to work with the bare minimum things or equipments that might be available to us. Like that will help us make more innovative, improvise on what basic things we have in our hands, like what equipment, instead of what equipment we can use something other thing. And also then we'll be like in a working setup, we'll be less complaining of what we don't have, and we'll be more appreciative of what we have in our hands.
But definitely, if your infrastructure is limited, it's your responsibility to see that it's actually acquired by that institution, and patient safety is the ultimate goal, I think.
Yes, sir, absolutely. But working in rural is part of
that's true. That's true. Yeah. So my point is just this: like, it's not about getting satisfied with what you have. You should always put your hand up and say, "I need a capnography monitor. I need a pulse oximeter. I need ECG." Because I think our societies, anesthesia societies, they are also encouraging us to speak up for in favor of patient safety. So,
but I think Nitu has raised a reasonably good point about the vast majority of a country like ours would need more of a community-based anesthesiologist rather than a super specialty or subspecialty-based anesthesiologist. And the training of the postgraduates in different levels of institutes exposes them differently to this. So is there something which can be addressed, or which should be addressed, which need to be addressed? We need to think about that.
Some rural posting might help, like some a definitive period, like 2 months rural posting in basic infrastructures like our community health centers or basic setups can maybe somewhat cover that part of thing, I hope.
Or at least the acute delivery of acute care in such situations, wherein if I'm a cardiac anesthetist, I should not be overwhelmed when I go to a village and I've been asked to anesthetize a person for a dental extraction or a hernia maybe. So these are the issues which plague us and which we need to address.
Okay, Arvind, shall we quickly go to the survey part and get our panelists' input on that?
Yeah, certainly. I think that will be nice.
Okay, fine. So I think we can divide our responsibilities. Like the first question was, how did you choose anesthesiology for specialization? So majority says they are compelled due to the rank in qualifying exam. The second best choice is they believe it has a prospects of an exciting career and they're passionate about it. 21 says it's a good specialty and there is a role for peer advice and seniors advice. I have a quick comment from Dr. Durga. Why do you think your peer group thinks like this?
Yes, so thank you for the question. This is something that even I came across when I was asking around to decide. So I think a lot of people are very much unaware about what exactly anesthesiology is, and there is a very huge misconception that anesthesiologists do not get enough patient interaction. A lot of my friends have had this misconception that that they don't get patient interaction and they want to be involved in active patient care, which I realized that it's not true at all. Maybe it is short-lived, maybe it is just for maybe until the period that we are taking care of them pre-op, during the op, and the next 2 post-operative days. But that few days where you start assessing the patient, when you develop a rapport with the patient, and when you when you hear a word of thanks from them, a lot of patients nowadays do ask and thank us for keeping them pain free. So that gives a huge satisfaction. So it's a huge misconception that there is no patient interaction. So that could be one of the reasons why people are not choosing the branch, and finally they just opting it just because they have not gotten the sufficient rank to choose whatever they thought was best suited for them. That could be the reason, one of the reasons. A lot of misconceptions about the field, and this is again due to the lack of exposure during their internship or MBBS time.
We are zeroing back to the same issue.
Yes, sir. And also, and to contradict that itself, nowadays, as we increase the amount of in spreading of information, like how all these YouTube and such social media platforms are coming up, and there are so many more opportunities for people to find out about the specialty. That could be another reason why more people are again finding out through other ways that in fact it is a good specialty with a good job opportunities, as well as a very wide basis. They get to interact with a lot of other specialties, and all those information comes through such platforms and webinars, and that could be why we can see that second highest people have chosen that because it's a good specialty.
I think we just cannot do away with this, because ultimately the medical entrance exam is based on ranking, which should not ideally be the case. I think interest of the individual interns should be taken care of, but I think that's beyond our scope.
Yes, sir. Unfortunately.
Yeah, and I think in the survey they have given the sequence that the key prospects in anesthesiology, that it gives wide coverage from ICU to OT to pain clinic, like the acute intensive care, up to the OPD based medical practice is there. They definitely believe it's a challenging specialty. There is a prospect of interaction with all the other specialists, because ophthalmologists, radiologists, obstetricians, psychiatrists, everybody needs anesthesiology. Definitely there is a point towards overseas career prospects. Of course, the good remuneration and scope for private practice also comes into the key prospects during our discussion. So the next point is how do you rate their preferred quality of an anesthesiologist? Can I get Dr. Anmol comment on it? Because I think all the voters have given at least 4 or above score. They strongly agree that knowledge of acute care is important, life-saving skills important, technology aided is important, fast decision-making skill, good team player, good team leader, and perioperative physician role, all are almost equally important. Your comments, Dr. Anmol.
Sir, as per the whole in showing on the screen, the most preferred quality as it is shown the life-saving skill of an anesthesiologist. So while doing the peripheral duties, we have been told when the patient goes into the arrest or while doing a difficult intubation, difficult cannulations. So it's we who are going to do all the difficult tasks which other specialty residents are unable to do. So that would be the point where we can either save the patient or we lose the patient. The task like securing an IV line, it's as important as doing a difficult intubation. If the patient is hypotensive or and we are unable to secure an IV line, so we will lose the patient. So the life-saving skills, the not just about the procedures, the knowledge of to handle all the emergency situations and the acute care is essentially important for an anesthesiologist. And the quality of being a good team leader and to assign the role to each and every person present in the resuscitation or in the OT or in the ICU, so that only one person does not get overburdened and that the sequelae of the events which we are expecting should not get delayed. So
I think, Dr. Anmol, you're making a good point that you're summarizing that all these points are equally important. That seems to be what the poll is saying. And most of us who have been in this specialty realize that the valuable inputs of all these, we have to wear all these hats. So that may be overwhelming in the initial stages of a PG, but I think towards the end, you feel comfortable that you're more of a well-rounded physician with all these aspects in your arsenal. Am I right? Is that something which all of you would agree upon? Shall we go to the next question then, Dr. Sanish? Yeah, very subjective question. Maybe if the pay packet at the end of the month is good, then you will be happy. Or maybe you have no failed spinals or no failed intubations, then you'll be happy. There are so many ways of looking at it. Dr. Aditya, what do you feel?
Arvind, still there are some people who are not sure whether they're actually happy or not. Because happiness is something that is subjective. We can't blame them also. Yeah, please, Aditya, go ahead.
So, as like the question is, are you happy being an anesthesiologist? Most of them will answer yes because we're doing PG. But then the thing is that once you enter first year, you're unsure whether you become a happy anesthesiologist later on. There are concerns regarding the poor pay in the corporate sector and the fact that you're dependent upon the surgical branches. So all these factors, they hamper, like they, what should I say? They may cause a drawback about the anesthesiology, and the people may not be happy about the anesthesiology branch. You feel that it is a dependent branch. You feel that you depend too much on the surgeons. You have to work with the surgeons. So that is the reason why people are not happy. So we have to create a situation where we are an independent branch, and we have to ensure a good pay package is available for all the anesthesiologists in the corporate setup as well as in the government setup.
That's good. That's one aspect. But happiness also can be the work-life balance which anesthesiology provides. You're happy getting time at home. Maybe you don't have wards to look after.
Yes, sir. That is one aspect, sir. But then the OTs will go on for a long time. You may not get time for family life. You have Sunday duties. You have to work overnight. So all these things are one thing which an anesthesiologist should remember while entering into anesthesiology.
But isn't that true with all other specialties too? Most of the other clinical specialties too?
Yes, anyway, sir. But then you can have unanticipated events happening in the OPs, and you can have even in the ICUs, you may have to stay a little bit longer.
Do you want to point out that as you become more senior, you are seeing that your responsibility and the stress levels are also becoming higher?
That is expected, sir. Like once you become a senior consultant, you will have to be responsible for more number of patients. More number of people will come to you asking regarding the patient. So as you grow a lot,
so you'll make more
senior,
enemies than friends in the hospital.
I'm not saying like that, but then more people will look on to you, sir. You'll be having to answer to a lot more people, and you'll become more responsible.
Good. Coming to the next question, what is your choice for practice in the future? So basically, do you want to stop at being an anesthesiologist with an MD or a DNB and then serve all branches, or do you want to narrow it down and go into the community or go into pain and be independent, as Dr. Arshid was earlier pointing out? So these are what the different, but nobody wants to choose palliative care.
Yeah, that was the thing I wanted to highlight. Actually, in this,
how many of you actually know what is palliative care among the PGs? Have any of you had exposure to palliative care as a part of anesthetics training? Because now I think palliative care is a standalone branch of DNP training.
Okay.
Yes,
Two things I noted was one, the score of 0 for palliative care, and second, actually it's a general practice versus subspecialization, because all the other options are actually subspecialty. So the great majority goes with the subspecialization and specialized skills training and extra concentration on.
Just to point out, I'm assuming that most of them know that critical care is not just a subspecialty of anesthesia. Even pulmonology and internal medicine, they also get into critical care. So you have to have some competition over there. So critical care is a shared area, kind of. I think this is something which we need to revisit in our discussion point later on. What do you think should improve in anesthesia training? Obviously, lots of things need to improve, including the corporate pay package and things like that. But we're talking about the training part of it. What do you think can be done more? Do you need to be given more independence, or do you need to be given more supervision, and so on? So,
want to share your thoughts?
Yes, sir. What I believe is, to be able to swim in the tide, we need to actually get into the water. So our bedside, our tableside skills and OT practices more of what we require than our just theory, or so like it's all under supervision during our MD course, but then more of hands-on and more of practice is what actually is required.
Do you think more of point of care monitoring for decision making? I think that's a point which most of them have put across in the poll, that you need more on your fingertips information to take decision.
Yes, sir. We need to be very quick in our decision also. So all that comes only through practice.
But then there's a point there which is protocol-based training. So all of us work like a robot. What do you feel, Dr. Prateek? You should be told that this hernia should be done like this only in spinal, or do you need to be given autonomy to work the way you want to do it?
Sir, I think that depends on the pre-anesthetic checkup. What I've seen here, what happens is all the residents go one by one and do the PAC. Then we were sent to another institution where I found out that they had a team where the team would go for PAC together, and they'll be discussing how this patient should be how should we plan this patient. They would write down the plan. So I found that really encouraging. So I think that we need to focus on the peri-operative care rather than just the operative one. So if we discuss the pre-operative goal, we'll ask how do you think we should plan? How do you think we should plan? And then go for the operation. So I think the pre-anesthetic part matters.
There should be more of trust on the planning and the peri-operative word which you used. So post-op pain relief, post-op care, but what about pre-op optimization?
Exactly.
So do you think we need more
when we are going for pre-anesthetic checkup, there should be a healthy discussion. There should be a complete protocol that we'll do this. What is your plan? What is your input? And that way, when the JR comes to OT, he'll be able to appreciate better what we are doing instead of just observing or instead of just doing the cut work. So I think that will involve people more, and that will give them a more holistic view of what is going on.
So the training should be more protocol based so that you learn all the aspects of it. But later on, when the practice comes, you are allowed to have your autonomy in planning.
Exactly.
Fair enough. Simulation-based training, the last of those points, how many of you are actually exposed to it? How many of you know about it? Do you think it's a good idea to put a mannequin and do everything rather than doing it on clinical cases? Or is it true only with certain institutions which don't have enough case load, that they are well trained on the simulator but not trained on patients? So what are your thoughts on this? Dr. Shanmugapriya? Yes, Sanish?
Yeah, Dr. Aditya Prasad.
Sorry.
Dr. Aditya Prasad.
Dr. Aditya Prasad,
comment
is he
on that?
around?
Yeah, you
Yes.
can unmute, yeah. So the issue is about the role of simulation-based training. I think there is some technical glitch. Okay, who else would like to speak on it?
Yeah, Dr. Janish, simulation-based training, is that a good supplement to actual hands-on training on patients? Or should it be a complementary to what you're learning? What are your thoughts on that?
Sir, I believe it should be complementary to our training. Like, I think it's hands-on training is always the best thing. That what we learn and what we do, we learn. I don't think a simulation from a mannequin or something. Yes, of course, we get to acclimatize to what is doing. Like example, if you're doing CPR, we can learn on that. We can, of course, like how to like position the patient and maybe how to keep your hands or
So
something.
you can use
Might
that
be
as for
mannequin.
repetitive training. That's what you're saying.
Yeah.
For repetitive
Yes,
training and for getting better, but it doesn't
yes, sir.
supplement what is actually patient care. I think it's a fair
No,
enough
sir.
point he has made, and good. Shall
No,
we go
sir.
on to other questions, Sanish, so that we can
Shall we
have
go to
completion?
Aditya Prasad once more?
Yeah,
His,
Dr. Aditya?
audio
Yes,
is
yes,
here.
Yeah.
I'm sorry. I have a little bit of an issue with the connection.
Yeah.
No worries.
I would say running simulation-based trainings will add a lot of method to the madness, which is an acute event. Because whenever something happens, people are not calm. I mean, it is hard to stay calm, granted, but the more times you run it through this kind of system. When you have a mannequin, you can prick, prod, and you can you can unconsequentially do something to. It'll add a level of consciousness and calm to your actual acute situations. And
And maybe ethical also, not to use all our learning on a patient who's actually dying, rather than do it on a simulator.
Yes, definitely, sir. Definitely, it's not fair. It doesn't feel fair sometimes to give the junior most kiddo a chance to intubate or put a spinal on a patient. Sometimes it's a gray area, in my opinion. Not sure whether it's
Good. I think it's
fair
made
or
a
unfair.
valid point which need to address as to how do we do this critical points when seniors are around, and seniors also have to evolve this. Okay, anyway, coming to webinars, I think last 2 years we have seen a lot of, even now we are seeing each other on a laptop, not face to face. So it's not hands-on, it's basically through a webinar. So do you think it's a good point that we have webinars, and we have seen the poll which says that it improves academics? So you learn more on the webinar rather than through books and through your OT interactions. Is that a fair enough point? Anybody wants to say anything on that? Less expensive and more.
There are more takers for the archives of recording in the YouTube. Is that true? PG panelists, your opinion, please. Yes, Dr. Rachna.
So they feel it can't be learned in one shot. You have to go back and see the archives again and again too. Dr. Rachna?
Still, there is some audio issue. Okay, Dr. Durga. Yeah, Dr. Rachna, you are back.
Yes, sir. So the use of archives and recorded videos is such that as being PG residents, we can go back time and again as per our convenience, and depending on our schedule, we can go and review and have a overlook on the topics and the discussions that have been done for a particular topic by a particular faculty. Also, it gives a resident opportunity to follow the faculty whom they like, whose teaching they are more preferring to, and also they can follow up with the current and the ongoing changes, new things that they can add up, and all those things are very much useful for webinar system of teaching.
I guess she's made a valid point in that. Now, all of you, do you have any differences? That she says whatever she's not a part of, also she's able to see it on archived video. Maybe a different OT, a different patient, also she's able to see it later.
But actually, we have seen some of the webinars being interactive. We have had OSCE sessions, Viva sessions, case presentations. Will it look nice during live program or as an archive? Dr. Nito.
So definitely one of the advantages of having an archive is the repeatability. Like we can see it and use it whenever we are comfortable, what time we are comfortable at. And one more thing about the webinars is that ours is a very technical and technology based oriented also, like our subject. So on webinars, we get to know about what is happening in the different spheres of the globe, and we are able to see and we are able to get a taste of what is the newest, what is the latest thing that is happening in our field. Just like this has brought us all together from Jammu to Kerala, what this series has got us to. We'll get to know what is happening in each and every part of the world. Like we get to know about the technology, latest things.
And the department is happy that they don't have to give you leave. You can do it in their laptop in the evening. So work doesn't get compromised. Yeah, it's 8:20, Sanish.
I'll give you one more clue. You're also getting to know some of the stock questions of the examiners, regular examiners also.
That's a very big tip you're giving, Sanish.
Okay. Anyway, this slide I have already explained how the budding anesthesiologists think about anesthesia. And I think we'll skip this question. Yeah, this is one thing we would like to take your input. What's your opinion on present examination system or pattern? We have theory, a viva session, and case presentation. For national board exams, there is an OSCE. So how do you think about the examination system? Quick comments before we get our senior panel in. Dr. Ramya?
Yes, sir, coming to the
Because
present
you haven't gone through the examination. So I think Dr. Pratik is the best person to comment on that.
Yes,
did he
sir.
get
So
assessed? Did Pratik, was he happy with the way he was examined now that he's become a professional after his MD?
Sir, I think the way that we are examined, it's a little old school, because we are presenting cases, we are given short cases, we are doing all these drugs and everything. But I think a OSCE based approach will be more appropriate, because in that way I'll be able to present myself more and able to will be able to assess the person better and in a very short time. Like there can be a station on patient safety, or there can be a station on what would you do in that case. And also on maybe on stimulation also, because for example, if somebody has malignant hyperthermia, how will the PG learn? So it has to be on simulation. So I think all these dummies, simulations on all these areas, that will be better. Yeah. And communication skills, that could be one of the stations. Exactly. So I think we need to
Don't you think the
evolve
present examination system already has that in terms of the internal examiner who sees you day in and day out and then makes an opinion about you? That's something I think which has been addressed, but maybe your suggestion is also right.
Sir, actually, when I did my PG, in the end of first year to beginning of third year, we were posted in COVID. And when we came in third year, we had to relearn the OT. We had to revise it. So when we came back to it, we had to see for patient safety. We had to relearn our training, and all that combined, which made it a little too overwhelming. But in the end, I think we need to evolve when it comes to assessments also. The present system needs to evolve.
I think that brings us to the next survey question about competency-based anesthesia education or training. So majority, they are unaware of this. Okay, I think we'll hear about more about it from Dr. Balabhaskar in the next session. So suggestion to improve anesthesia training, I had gone through most of the responses. It's very interesting. Many postgraduates or the survey respondents believe that there should be good supervision. Many are emphasizing on protocol-based learning and more focus on subspecialties, specialized training on skills, point of care monitors. Some are very meticulously jotting down points why he or she loves anesthesia. Targeted approach, opportunities for discussions. That is one thing that is common. We need to generate more opportunities for case discussions, either earlier in the day or once a week. A clinical discussion within the department is what they seem to suggest. And I think we are through with our survey part. Any last final comments from our PG panelists before we hand over to the senior panel. Okay, from Dr. Arvind.
No, thank you. I think we have covered a wide gamut of issues from everybody. And I agree there have been some duplications in the thoughts, and some of it has been overwhelming. The word overwhelming has been used overwhelmingly. But now I think we should go back to our seniors and put across these issues. They have also patiently waited with us and heard all our issues. And their learned comments and wise thoughts also are going to be very important for us.
Okay, with that, I'll invite Dr. Radhakrishnan, President of ICA, to lead the panel discussion from the seniors' perspective. Over to you, sir.
Thank you, PG panelists and moderators, Sanish and Arvind. Thank you very much. On the whole, it was a good discussion. I mean, enjoyable discussion on certain aspects. But personally speaking, some of us, especially me, I did not get what I wanted from my student panelists. We are looking at one thing. What are the hardships they're facing? Or what are the fallouts we have? So that we could resurrect and bring out something new for you. Anyway, most of the areas you have touched upon. And we also will be presenting our view. Like you did, in fact, we have 5 panelists out here. We all will be taking 5 to 7 minutes. Within 1 or 2 minutes, we will be giving a complete overview of what happened. And later, on 1 or 2 items, we will be dilating further. So if I look at, I must say, I'm a person who came to anesthesia by choice. By choice, I mean, I was free to select what I wanted when I wanted to join. I could have gone to any particular specialty. Only thing that at certain institutions, marks was kept as the basis of selection. And most of the government institutions, well, marks also was kept as the criteria for selection. Probably some sort of a interview also for a namesake interview. Wherever you want, faculty members, you are allowed to join as a faculty member in the junior most grade as a tutor or as a junior lecturer. And those things changed. Now it is your mandatory luck. By mandatory turn, you go into an area depending on your need score. And from what is available there, you select a specialty which you think, which is maybe good for you. And probably in the first 6 months, you are trying hard to get that particular specialty well tuned to your likeness. And most of the time you pass in that, you may be able to adjust well to that particular specialty. Then you start learning. Unfortunately, in India, or say in Asian countries, we don't have any system called a recounseling. Whereas that is going on in UK, Canada, or America, or Australia. That means after 6 months, if you are not liking that particular specialty, you can go back to the dean of the institution. The dean will conduct an interview and decide whether your claims are correct, that you are not able to cope up with that particular specialty, and you will be allowed to go for another area. Anyway, that's not going to come to India. It may take some more time to have that particular change. Now, regarding the period of work, now we have only 3-year courses, either with a national board or with a medical council, not medical council, medical commission. We have only 3-year courses. Today, what we do is that, in fact, I should not say today what I do. Probably I would have been doing it in the past 44 decades or 40 years of my teaching career. First 6 months, we will give all you awareness only, because we are not at all pushing you to any brain. We will never do that. None of us will do that. No teacher of worth will do that. And in first 6 months, you are allowed to move around wherever you want. That means you are getting used to the specialty. Then from 6 months onwards, till the 30th month over, 30 months, that means nearly 24 months, you will put to the hardest way. That means training goes in a different level. you are put to most of the areas and you'll be taken to all sorts of tasks in training. And by the end of 30 months, we as a teacher make sure that you are okay, you are satisfactory, you could be put independently, and the next 6 months, or say the last 6 months, relatively free for you. That means you can wind up, you can brush up your study, you may be able to finalize your thesis, and all sorts of things going on there. In fact, this was a system which was followed, and even now that system goes on at most of the places. But what I look at is that even though we say all these things, everything is not practiced very well. That means some of you were telling that during a house residency or your internment, I mean your primary internment, you are not given that much exposure. That's correct. Even if you are given exposure, you are not going to learn because you have not made up your mind what you're going to do. Is that even today at every medical college, wherever I go, what I see is that the houses, they'll be reading the NEET book. They'll be preparing the books for their entrance examination. They are not worried that much about the particular area where they have to master, whether it is a lumbar puncture or say intercostal drain or a knee aspiration or a dressing of the wound or the ear examination. You are not that much keen because you are all, because within the shortest period of time, you want to get highest NEET score and get into the post-graduation. That means you want to go for post-graduation. So at the auxiliary period, well, you are not given adequate exposure. It's not absolutely correct. You are given, but you don't have that much of time to go ahead. But at certain places, at certain institutions, I have witnessed that they will take this anesthesia auxiliary time also for somebody else. So more powerful in the board of studies will take up that particular 15 days of training also for their particular purpose. They say in the medicine or surgery or orthopedics, they will take up, they bring the students. Or sometimes rotation is not possible for everybody in every area. That also is possible sometimes. Anyway, those are some built-in faults, which I am sure the present management or the present boards are trying to correct it. Now, one thing which I wanted to say about the PAC, well, one of our friends was telling about the group PAC. Well, group PAC is good, but only at very few institutions where you have large number of postgraduate students and large number of faculty. Well, you may be able to do a group PAC. But at most of the institutions, faculty is not that much. Students are also less in number. There you cannot have a group PAC. And again, group PAC also has some particular problem because always anesthesia is administered to the patient's choice, not your choice. You always look in one day, well, whether the patient is fit to undergo anesthesia, general anesthesia or regional anesthesia. Well, when that particular matter is decided, when this particular patient with the ailments or with the disabilities, patient is not good for general anesthesia, we think about alternative. And then we discuss with the patient, well, I may be able to give you this sort of anesthesia. What do you feel like? But it takes time. It's not possible in India at present. It may be possible in a large institution, but not in every institution. But this is definitely possible. Or the insurance people say that this is made must if you are in developed countries where patient's willingness, patient's comfort, patient's choice of anesthesia is given. My colleagues in the senior panel, they may be able to differ, or else they may be able to support on this particular matter. Yeah. Examination system. Well, examination system need change. That is being brought out as far as I know about. Yeah. And now, anesthesia, I may say, is a middle order specialty. Middle order specialty in the means because now the rush is for orthopedics, obstetrics, gynecology, oncology, general medicine, these sort of areas. And the next in the middle comes anesthesia and all. But this is not the situation where the money which comes from anesthesia is almost equivalent to what you get from obstetrics or some critical care or some plastic surgery. There, the priority is almost made equal. So at present in India, well, we can say we belong to a middle order priority. Definitely not in the order as skin or physical medicine, rehabilitation, or say psychiatry, where more time is available to you, work is less intense. And other thing, uniform curriculum and uniform syllabus. Syllabus is uniform all over India. Syllabus for national board examination or syllabus for medical commission. It is the same syllabus which is me. But curriculum, depending on institution or depending on the particular medical university where you are, they modify the syllabus to suit their weather conditions, as well as faculty availability, as well as the need of that particular area. So the syllabus is same, but the curriculum differs from. But I don't think there is not that much of difficulty in making it uniform syllabus as well as uniform curriculum. But anyway, this system is working out well in the last couple of years. So, well, we leave it to that. I don't think we may need any sort of a change being brought over now. And rural postings, which you are mentioning, at very few institutions only, we have rural hospitals where anesthesia service is being given. Very few institutions. See, I'm from Trivandrum. Trivandrum Medical College has only one institution where in the rural postings, well, you may be able to practice anesthesia. We don't have that many postings. But instead, the government, if they want, they can think of that students, postgraduate students, after 2 years of completion of their training, they could be put to district hospitals, or say taluk hospitals, or say general hospitals in the public sector, where they could be given more training and more practical lessons on what is happening around, and with their skill, what they could do and what they could probably learn for future. That could be done. That's a good suggestion that we may be able to think about it. With this much, I am giving out to Dr. Jayashree to make her comments and dilate on certain areas which she likes. Jayashree, please. Dr. Jayashree, are you not free or are you not there?
I'm free. I'm free.
Yeah, please.
Yes.
Make your overall comment and certain areas which you like, you dilate.
Yes. Good evening, everybody. It was a pleasure listening to this conclave, and especially to the students. I must congratulate them. And of course, coming to my thoughts on this teaching, PG teaching that we have been discussing with different views from all the students, of course, there were many valid points that have come out, and of course, everything needs elaboration. But what I feel is rather that what things were many years ago when people were taking this, opting for this specialty as a compulsion, or since they had no option, nowadays trend has changed. The students have become more aware of the different specialties, especially because they are rotated during internship. If they are lucky, they are rotated in good hospital. They go to do their internship in good hospitals, and they have maybe even a 15-day rotation over there. And that is the time, if it's a good department, how they teach, like the interns come to our department for internship. We have a regular teaching program, orientation program, basics about ACLS, BLS, as well as other parts of the pain. They take the pain rounds. So I meet these students later on, and some of them do tell that, madam, when they come for the completion, that madam, we are so impressed by this specialty that we're going to opt for it. So things are changing, and I think it's the responsibility of we seniors to ensure that these students are given a overview of our specialty. So that's important. And of course, there's a slight difference because now we have this NEET exam, which is common. And so the DNB and the MDs decided over there. There's a slight feeling that DNB still, or the MD actually scores over DNB. So sometimes we do see, although the students do opt for a DNB anesthesia, if they do get a chance to do MD, they try to change. However, if not so, then they do continue over here. And of course, I agree with the students, of course, and of course the faculty that yes, orientation, the course is 3 years, but you can't just give a patient to any student. That's very important to anesthetize. Simulation, of course, which is very common in other tertiary care centers, may not be available in others. So definitely in the first 6 months, it is ensured that the students rotate through all specialities, undercover, they actually read, they see what's going on. And later on, possibly after 6 months, then they are given the basic OTs, which is basic, what I mean is by the general surgery OTs or the gynae OTs, where they can practice airway, which is the most important and the critical. And then gradually, after they do that, then they go on to a slightly more advanced area. And then of course comes in the final year, the super specialized or the subspecialization or the areas where they cover. So each department has got its own protocol, and this is how it is usually followed. Like the students were saying that we would like to do things independently. Yes, we always allow. We pretend that we are not with them, but we are always looking at them, what they are doing, and that's very important. So they feel they're alone, but we know what they're doing. We are watching them through our monitors, remote monitoring, or even through the glass windows quietly what's happening. So all these things are there, and definitely they do help. And of course, it is the guides or the head, senior consultants or the head of the departments that they become mentors to these students. A mentor is important. You should behave like a mentor, a guide, and where the students can confide. All these things do make a difference in the teaching, because the students are with us for 3 years. And it's important that when they leave the institution after the exam, they should always have a good feeling, and they should always be happy that they went to an institution, to a specialty, where they not only learn the technical skills, but also the non-technical skills. And I'm very happy that these students have pointed out all these things, and I'm sure they're all doing a very good job, and their thoughts, of course, which they have expressed, we have also learned through them, and we will also try and improve our ways of working in the department. Thank you very much.
Thank you, Jayashree, for your comments. In between the PG panelist discussion, it came up regarding the palliative care, critical care, pain, and all these things. Well, I must say, except the palliative care, the critical care, or say the emergency medicine, or say acute care medicine, or the intensive care medicine, all are always, not anybody else's. It was always, now it is slightly drifting, because we are the only one who is well trained for 3 years for the volume management, pain management, as well as for the ventilation. Nobody else is taught that way. But unfortunately, our people are not putting up that much of effort on this particular thing, or they don't want to specialize too much in this particular area. That is the reason why these areas are drifting. And moreover, we are looking for more towards a comfortable job. But anyway, please don't go and tell that this particular area belongs to somebody else. So pain management, disaster management, or say disaster medicine, emergency medicine, intensive care medicine, acute care medicine, all part of anesthesia only. Little bit of medicine, well, some areas it may have some overlay, that's all. But palliative is an entirely different thing. Palliative actually anybody may be able to practice. You don't need that much of knowledge in one particular area, that much in depth. That's one thing. Secondly, now I request Dr. Baljit Singh to analyze the examination system with the National Medical Commission as well as National Board of Examination in the light of discussion we had today, and what all developments one can expect or how we may be able to bring it up and what may be good for us. And this along with some other areas which you like to dilate on the discussion.
Right. Thank you so much, sir, for the opportunity. First of all, I would like to start with complimenting all the postgraduate students for bringing out wonderful opinions. I think it was kind of an eye-opener for some on some of the points. They were very, very clear what exactly they wanted to express, and they did it. So my special compliments to them. The next thing that I would like to say that that's my personal opinion. If there is one specialty which has grown the most in the last 2-3 decades, it's been anesthesia. At my time when I joined anesthesia, I mean, MD anesthesia was the end of the world. There was nothing more than that. Or people would do diploma and the whole life they would be very comfortable with diploma, working in private sector or working wherever. But now see the opportunities that we have. I mean, we were talking about pain management. We were talking about palliative care. I'll come to palliative care again. Critical care, yes. Emergency medicine it's a new area that more and more anesthetists are going into. Of course, cardiac, neuro, pediatric, obstetric, they are all further diversifications of the anesthetic course. Coming to palliative care, you just mentioned, Dr. Radhakrishnan sir did mention about the palliative care. That, you know, and in the graph which Dr. Sinish had shown, there was no one who opted for palliative care choice. Now, I think why it hasn't become popular among anesthetists is that the awareness about palliative care is very, very low. People don't know exactly what the palliative care physician has to do. Now, think of Dr. Radhakrishnan, you would be knowing so well because he's very, very closely associated with you, Dr. Rajgopal. And people like him who are pioneers of palliative care, where were they about 15-20 years back? Because there was hardly any awareness about it. But now people like Dr. Rajgopal, Dr. M.T. Bhatia, and so many others, they are celebrities in their own right. I mean, the patients and the people really worship them for the treatment that they get from them. So I have a feeling that in the coming decade or so, palliative care will be another exciting opportunity for the anesthesiologists to diverge to, rather than not just cardiac anesthesia or pediatric anesthesia or neuro anesthesia. In that case, I view anesthesia not as a middle order specialty. I'm sorry, forgive me for not contradicting, but I'm just expressing your opinion. I take it as a mother specialty. There is no other specialty in the whole medical world which has so much to offer as an option subsequently after you attain your post-graduation, whether it is MD anesthesia or it is DNB anesthesia. So to me, this is the best specialty. Although when I joined anesthesia, to be honest, it wasn't my first choice. I was mad for surgery. Anyhow, that's a different story. I joined anesthesia, and after about 6 months, I was assured by the management that yes, you can shift over to surgery after 6 months. Anyway, so then after 6 months, I realized I became wiser that this is a great specialty, and I did not opt for anything else. I just continued with anesthesia, and I'm so happy. And I think whatever I've achieved in life is all because I'm in a specialty which is a great specialty. It's a wonderful specialty. It's a very rewarding specialty. Although I agree that the patient interaction is relatively less as you have, as a surgeons have, as a physicians have, or whatever. But then whatever we get from patient care as a silent patient care workers, I think I'm a very happy man. See this COVID, apart from the disaster it has caused the world over, it has done something to our specialty as well. It has brought forth the specialty anesthesia as one of the best specialties, and probably the anesthesiologists are now household names. Earlier, who knew anesthetists? They, if at all, they knew about anesthetists, they only considered it a gas man kind of feeling that या तो ये ड्रग लगा देंगे, ड्रग दे देंगे, पेशेंट बेहोश हो गया, उसके बाद ड्रग बंद कर देंगे, पेशेंट उठ के चला गया घर, and the things are so simple. But now they know that, and anesthesiologist is not just a man who just gives injections or a gas. He is an authority in his field. Look at resuscitation. If there is a patient who collapses in the cardiology department or in the medicine department, who is called? It's an anesthesiologist. Cardiologist can't do cardiac massage. Very few of them would be doing it, and not as per the protocols of whatever organization that you follow. It's only the anesthesiologist who is looked up as the last person. They say, although I don't fully ascribe to it, that if there is something between death and the God, it's the anesthesiologist who can fight that, that area. Okay, coming to the training, teaching and training, I fully agree. Some of the panelists, younger panelists, they did mention about the simulation-based training. I'm all for it, because rather than trying your hand directly onto the patient, I think anesthesia is not the specialty to leave it to someone who's absolutely junior, say a difficult intubation case or a difficult spinal or a difficult epidural. I think it's better in case we have some sort of simulation-based training, so that by the time the anesthesiologist, the youngster, the postgraduate student picks up a needle or he picks up the laryngoscope to intubate a difficult intubation patient, he has enough experience and he's confident that he'll be able to do it because he has done it on simulation, and he is more empowered to do that procedure. Examination system, sir mentioned about the examination system. Does it need a change? Yes, I think it does need a change. Rather than going through the conventional system of reading in the last 3 months and putting it on the paper, whatever question is asked, getting through the examination, is one thing. I think this is one system which is gradually now changing over. Some of the younger panelists did mention about OSCE. Yes, that's one change, and there is talk about on-site assessment. Although it will add stress to the student, that's what is perceived, that every now and then there will be an examination, say every week or every month or so. Just like the engineering students, if you look at IIT students, their examination, if they keep on coming. I mean, every week, every 10 days, every 15 days, there is examination. And it's not that it is announced like a roster that, on such and such date, there will be an examination on this particular system. No, the call comes or a message comes from the teacher, tomorrow, 10 o'clock, come there and there will be examination. So that sort of thing, will keep the knowledge base going on for the postgraduate students, and they would learn it as a continuum of knowledge, rather than reading up books in the last 2 or 3 months before examination and writing the paper and somehow getting through. So these are my specific observations on whatever the students have discussed, and I would now pass it back to you, sir.
Thank you, Bridges, for bringing out your views on the present examination system, what possible in store for future. And well, we were all thinking whether we need a drastic change in the way we are nursing you or protecting you or leading you. Well, I was thinking you all may like the mentoring of you. That means you are being mentored and you're going to be our mentee, and how you should be put, or the course or the direction to be given to get a successful career for you. In fact, our idea is that, in fact, probably we will be looking on how we may be able to effectively put up the mentoring system through the college as well as through all the anesthesia organizations. Probably we may be able to do that. Another question which I was hearing is that, what am I supposed to do? Nobody is telling us. Well, we are telling you, after you pass your MD or DNB, you have 3 different choices in India. That means if you want, you can go into academic career. Other thing is that if you don't want academic career, you can go into the practice career. That means you could be a practitioner throughout your life. You may be able to. The third thing is that you can take up fundamental research. But unfortunately, as stands today, there are not that many institutions doing fundamental research in anesthesia in India. Probably in another 5 years' time, I'm sure it will come up. And Dr. Balavaskar is going to tell more about all these things to you. And if you don't want to be in India for your success further years, you can think of going out of the country. You can go out of the country. And when you go out of the country, you go on a definite goal. And that goal is either of the 3. That means either for academic glory. That means you want to have some Western education, Western anesthesia education, and you want qualification there. And after that, you may plan whether to settle there or come back. The second thing is that you want to make money. If you want to make money, that also is a very good idea. Work for some 10, 15 years, make enough money for you to carry forward, and then you come back to India and settle. The third thing again, you want to settle outside India. That particular point has to be decided very carefully. You should select an area where you may be able to have a comfortable life. And there you may have to settle even if it is for less money. That means your option, when you think of going outside also, based on 3 different points, this also you have to think about future. So now I request Dr. Balavaskar, who is the professor and head of the department at Bellary Medical College, who is known to you so well, is an eloquent speaker, writer, our general editor for a couple of years, and he is going to teach you and tell you about what is fundamental research and what research facilities now exist, and how, if you want to have a career in that, how you may be able to succeed. As well as he is going to tell you about the competency-based education, competency-based anesthesia education, along with other systems of education, and the new things which are coming up, say in the nature of artificial intelligence augmentation, and how far they're going to affect us in our anesthesia education and practice. Over to you, Dr. Bala.
Thanks a lot, sir. Thank you, and it has been an excellent discussion from both sides today. In fact, the PGs have been more well informed than I anticipated, actually. So it makes more challenging for us as the teaching faculty. But in fact, they were able to express it also better. And we have taken some messages from their presentation today. And we also realized that we have got certain limitations and drawbacks, mainly because of the system. So let us also discuss a little bit from our perspective as we go along. And for a beginning, you were suggesting about the research aspects, sir. One is as part of the course of MD or DNB, one of the things that is made mandatory is for the students to conduct research in the form of dissertation. And of course, it's not the whole of the course. So the 3 years of their course, they are expected to pick up a research topic. And normally over a period of 1.5 years, in the sense after the first 6 months, they are expected to submit a synopsis based on the guidance from their teacher, then take it up for the next 1 year. And at least 6 months before the final examination, they are expected to submit their final project. So this is the one which is normally expected. And of course, the same thing happens in both the NBE as well as the NMC institutes across the country. But as sir was telling, as many of us, including me, sir, Dr. Balji, Dr. Jashi, and everybody here today, we have seen the best and worst of both the things, both as teachers or guides, or as the experts who go through the submitted research in the form of dissertations. So we have found what are the lacunae, and we also try to discuss among us and our group also what is the problem basically. So what we have found is ultimately it is something to do with the system. System means if it is me as a guide and if I am not well informed and I am trying to give a topic to you and I want you to implement that topic in the research and take it forward, then analyze it and try to prepare the final dissertation, I should have at least a certain average knowledge. Okay. So if you look at some of the incidences which took place about 30 years ago, many of our senior colleagues here would also agree. There were extremes of copy paste which went in different university dissertations. That was not restricted to anesthesia alone, across all the specialties. So luckily, there has been a gradual improvement in the quality of the research as part of the dissertation, because many of us as faculty have also been able to improve ourselves, and the same has been conveyed to the postgraduates, and they have also responded by understanding the system. And recently, if you look at the National Medical Council, which is also now we have got, I think you must have passed the examination on basic research, is it not? So it has become mandatory for all the PGs taking admission since last 2 years to take up this examination as a precursor and ideally before you start the research work. So that has helped us a lot basically. And in terms of the basic research and clinical research, I think that's what Dr. Radhakrishnan sir was proposing. So all of us are interested to just talk about, on an average, even I see or everybody, all of us will see, we talk about the spinal anesthesia, we talk about epidural anesthesia, we talk about giving bupivacaine with, initially there was fentanyl, then we talk about, before that buprenorphine, then now we have got dexmedetomidine everywhere. It's given everywhere. It's given oral, intranasal, intrathecal, epidural. Only thing is, I think parectal is pending. Mainly because it is very costly. I think when you are able to give it orally, we can also administer parectal. But to the extent there is so much of scope. But what I'm trying to convey here is the field is limited. Majority of the institutions, 80% of the institutions, I can say, or if 80% of the research projects that are being submitted by the DNB students as well as the MD students is basically limited to certain basic topics. Or you may talk about intubation responses. I still see people talking about beta blocker and lignocaine to attenuate the intubation responses. And I still see people talking about an epidural drug being given, and you just check the motor block and sensory block and everything. So, and airway. So all of us will still talk about predictors of difficult airway. So when we have already 10, 20, 30 predictors, we always end up telling that this is none of these predictors is sufficient. Sensitivity, predictability is different for these things, and we say again further research is needed. So what I would suggest our PGs to is to sensitize themselves beforehand. I know there is limitation because they are expected to choose a topic within 6 months, and when we fail as guides in terms of picking up the topic and directing you, guiding you for a proper implementation of research methodology. So I would advise you to attend some other research methodology workshops. None of our, faculty will discourage you from doing that. So please be on the lookout for research methodology workshops. Please attend, and it is going to help you a lot in terms of improving your understanding of the topic, number one. And number two is understanding the implementation aspect in terms of the methodology. In fact, one of the things which can be learned in journal clubs. So actually, journal clubs is one of the types of clinical teaching aspects. I don't know how many of you are exposed to journal clubs in your institutions. That should be part of the routine protocol, wherein we have one of you is guided by the moderator. We are going to read actually a publication, and we are going to critically analyze that particular subject. So it is critiquing. So advantage of critiquing is you try to know what is correct, what is not correct in that publication, whether research was correct or not, whether there were lacunae in that, and whether I can correct it or I can understand better and do things better. So this is the aspect which we learn when you you yourself pick up. In fact, I will suggest that you pick up a journal topic, journal club, go to your moderator, tell sir, why don't we have a journal club instead of having a regular clinical presentation or a case presentation or something like that. So this is one I would suggest you to take up so that your research mindset would improve, apart from attending some research methodology workshop. And with respect to going back to certain basic research, we have still some limitations. When I say about extreme basic research means lab-based researches. So is it possible for me to do pick up a new drug and use a drug in animals? Can I do animal studies? Can I get some responses? And can I do it on a larger scale? And do I understand about the various regulatory bodies related to doing an animal study? So these are some of the things which many of us are not adapted. So including us as faculty, we are not so familiar with these things. So it is a little bit difficult for us. And the majority of the institution, again, we don't have facilities for basic research. So it's like I should be actually going to the laboratory. I should be sitting and I should be even trying to pick up some molecular studies and other things. So this is the one which is pending. But definitely I am more happy with simulation-based research also. For example, if I am trying to do something new, so I will not be doing it in an animal. I will do it in a simulator, number one. And if I'm happy with the methodology and the outcome, number two, what I will do, I will pick up volunteers, healthy volunteers. I'm comfortable with the results and the outcomes in healthy volunteers. Then I will decide to implement it in a single case. Okay, I think you'll understand. It's like a mannequin study or a simulation, number one. Number two is doing on healthy volunteers. I'm comfortable. Number three, I will apply it in one or two patients, real patients, of course, with formal consent. I find it is very comfortable. Then I go to a case series. Instead of going one or two, I'll do at least 3, 4, 5, 6. Then I am comfortable. And I take it as a larger project. So this is the way we have to take up the project. And when I'm trying to tell, maybe it will be too much for you to understand as a postgraduate, but definitely it is the responsibility of the PG's guides to undertake all these things and introduce some novelty into the research topic. But I will again convey to you that MCI and NMC wants you to learn the research methodology, basically, not that you should do something new and something extraordinary. So that I will reconvey to you once again. But having said that, I will want our own colleagues, us as the faculty or the guides, we should also think of doing something new and guide the PG. Okay, because it is asking for too much from the PG because they are there for only 3 years and we are expected to learn research methodology. But we should guide them to do better things, even with the existing research facilities, existing clinical material. So that's how we can do. For example, one of the simple things I will be quoting in different research workshops would be when I administer spinal anesthesia. So normally 99% of us, 100% of us would, when we have an additive, so we'll take it in the same syringe. Okay, very simple topic. So for example, bupivacaine or ropivacaine or whatever, I will add fentanyl, I will add, for example, Dexmed, whatever, whether it is permitted or not nowadays. So very simple topic. I tell them that why don't you use your mind? So I will tell them, why do you want to combine? Why don't you think that I will give them sequentially? Okay. So on the ground level, when you mix two drugs, the pharmacokinetics might be affected because the physical characteristics will change. So for example, the basicity will change with respect to that particular reagent. Its pKa could change. So these are the things which could affect the pharmacodynamic effects of that particular agent. So I just give them an example. I said, why don't you separate them out? So what if I give a local anesthetic first, followed by the additive drug, or I give the additive drug or followed by the local anesthetic? So this is how you should be trying to think in your mind that something new can be done. So this is the one aspect I will always convey to everybody. And number two, next part is Sir was talking about something called artificial intelligence and other things. So in fact, this is again left to the facilities in the institutions. In fact, the simulation centers, the advanced simulation centers, they are there in some other institutions. Not some, many of the institutions are there now with advanced simulation centers nowadays. So they use a lot of artificial intelligence. So artificial intelligence would help in coming to, they are based upon certain algorithms. So based on the algorithms, you straight away come to some conclusion with respect to the efficiency or effectiveness of particular device. And in terms of trying to put things in perspective when you talk about the pharmacological agents which we use. So we are a little bit away in terms of using artificial intelligence for the sake of various basic research for the postgraduates. I will agree it's okay for an advanced research for a faculty himself or herself to take it forward. And sir, one more thing you asked was, sir?
Yeah.
About
education system.
Yeah, education system. So I think there was something.
The competency-based education system.
Yeah. CBME protocol. So in fact, I can always club it with. I think Pratik was talking about roles, what I should do in the first year, second year, and third year. He said he was not so sure. I think so. What I would say is definitely the CBME protocol. The document brought out by the NMC has got clear data on what should be done by the postgraduate in terms of his cognitive domain, in terms of the affective domain, in terms of the psychomotor domain, in the first year, second year, and third year, and even it is split up in terms of 6 months each. So, for example, if somebody is in the first year, so what it says is in the first 6 months, somebody should be taught expertise in the management of uncomplicated cases like ASA 1 and 2 cases only. And the PG will only observe. He is not going to do anything in the first 6 months. Then they talk about what is safe anesthesia, what is effective anesthesia, what is CPR, then how do you prevent or treat pain. So these are some basic things. Then they have written about the next 1.5 years. Then they say you have to expand your knowledge and administration. You should get trained in administration of GA in ASA 1 to 5 patients. So whatever. So initially first 6 months you are expected to handle only ASA 1 and 2 patients. The next 1.5 years you are allowed, you are given the liberty to manage patients even up to ASA 5. Then they have talked about individual breakup of the blocks also. So it's not exactly true that the administration is not doing in terms of NMC or the NBE. Clear-cut breakdown overall covering many types of blocks, many types of anesthesia techniques are given, and in terms of specialty also. So in the next first 6 months, you are just going to attend general anesthesia cases of general patients. And second 1 year to 1.5 years, you are going to talk about the specialties, including transplant, including the pain clinic, including going into NORA situations, non-operating, outside OT situations, radio diagnosis and CT scan and other things. So these are also clearly explained. So what is imperative is on us or the department or the hospitals to see that you are given these trainings. So there should be a protocol which is created and implemented. Creation is already there. It is the duty of us as the teachers and the departments to see that you put up a table, say, for example, Dr. Pratik or Dr. whoever is there. So you put it in the log book and see that they are ticked, whether they have attended to the learning requirements, including psychomotor domain, based upon the NMC and the NB protocol. So it is very much there. There is no problem at all. And in fact, in the last year, you are expected to know everything. So in terms of what you do in terms of major cases, emergency cases, selective cases, and everything, and also the ancillary subjects from the day one. So anatomy, what you should do, know, biochemistry, what you should know, physiology, what you should know, and in fact, including physics related to anesthesia. So everything is given with clarity. And also, you are talking about the exposure of undergraduates to anesthesia field. For example, MBBS students and posted to anesthesia. And in fact, we should be happy that even the CBME for the undergraduates covers clearly the anesthesia field also. For example, there is a topic on preoperative assessment for the undergraduates. So for example, they should know how, and they should know how to implement also. There are some abbreviations which are also given there. And they know the basics of GA, regional anesthesia, and local anesthesia. Then work on an airway with respect to the airway. I mean, mannequins. With respect to airway mannequins, you have to demonstrate how you intubate the patient, how do you hold the mask, and these are also part of the CBME for undergraduates. So, in fact, both our boards are doing good. So it's again left to us as the teachers. And in fact, I think it is a responsibility of the postgraduates also to start teaching the MBBS students. So whatever you know, basically you are always better. You have learned about anesthesia and airway management and resuscitation and fluid management, pain relief already. So definitely you can also take it upon yourself, then talk to the house surgeons or the MBBS students who are posted, engage them, and you also discuss and share your knowledge with them. So this is the advantage of CBME, and clear-cut tables are given in the documents of NMC. So this is the future. This is a way forward. I think definitely anesthesia teaching per se is improving in terms of CBME, and in terms of simulations. I think the basic CPR mannequins are available everywhere. And I think now I know NMC has made it mandatory that a certain numbers and certain types of mannequins are definitely to be used, and it is part of the mandatory requirements for all the medical colleges. So they have given, I think, based upon the number of students, for 100 MBBS admissions, there is a list of which type of mannequin is to be procured and how many numbers have to be procured. So these details are also available. I am definitely optimistic with respect to the level of training for postgraduates, and I am also optimistic about the level of training for the undergraduates. So, but only thing is, I will just take this opportunity to also push our postgraduates a bit. So, all of you have done well expressing your opinion. Dr. Radhakrishnan sir, I'll just take another 2 minutes just to ask our postgraduates whether they were able to participate fully and understand their responsibilities. What I want from the postgraduates who are participating first year, second year, third year, you also be proactive. I would want you to go behind your teachers, then ask them questions on the bedside, didactic lectures, in the OT also. You also become more, active, ask them questions and involve them and engage them. So otherwise, if unfortunately, I'm sorry to say that this type of participation from post-graduation has come down a little bit over the last few years. I don't know about the experience of my colleagues otherwise. So this type has happened. So probably it is also attributable to your smartphones. You think you can just Google and get some knowledge, and that is the best one. So that is the negative aspect of Googling. So I will want you to disconnect yourself from Google. Please get behind your teachers, and in fact you also ask for some questions and go for homeworks and get back to the teachers, and that is the way forward. And in fact, even for seminars which are being conducted. So I remember when we took up the seminars, we'll open up the textbooks, we'll open up Miller, we'll open up Chris Roberts, we'll use Wiley, we'll write everything. And sometimes we will have OHP sheets which are prepared, and my file will be at least some 30-40 pages. So advantage is I think we will, if you do this based on this type of preparation, you will become master in that field. Till you have the knowledge of anesthesia at 50 years, 60 years, 70 years also, you will still remember that subject. So what I'm finding in current generation is again a little bit of copy and paste. So greater instance copy and paste is there from again soft copies. I would want you to read, understand, type it yourself, even if it is a copy, but please type it yourself so that you will understand and you are able to convey better. And one more thing is the mobile aspect. Once again, but if you reduce the mobile usage by about 30%, your knowledge would improve by another 30%. So that's my take with respect to the training comments from us as specialists. Thank you very much.
Thank you, Dr. Balabhaskar, for elaborately explaining on the possible research methodologies which we may be able to adopt, as well as on the artificial intelligence which is coming up, and then the so-called competency-based medicine medical education which is put into practice. Thank you very much. Now I request Dr. Anida Malik, who is a professor and head of the department earlier with King George Medical University, and who is a innovator. I mean, I may put it as a all-time innovator in medical education. She may be talking about modular training, modular teaching, how far possible or what is applicable in anesthesiology practice. Dr. Anida Malik, please.
Hello. Hello.
Hello. Yeah.
Hello.
Hello.
We can hear you, Anita.
Yeah.
Yeah, we are hearing you.
Okay, ma'am. It was indeed a nice platform to interact with the PGs and the comments with the senior faculty provided. It's a very, very large and vast area. But what I feel is for anesthesia postgraduate, the backing of knowledge is very important for performing different skills, taking decisions, and performing their tasks. But they are so busy in overall OTs, and the OTs are running from say morning till evening. They don't get much time for self-study, and the self-study is very much required. So to substitute that, I think that the whole of the syllabus can be converted into different modules. And this modular teaching we applied in our institute also, and that was a success with our PGs, and they were very happy about that. So this modular teaching is something like that, that full syllabus is divided. Here I have subdivided further from after discussing on the ICA platform with Dr. Baljit Singh, Dr. Radhakrishnan, Dr. Murli, and all of them when we talk, we further subdivided these. So overall the modular teaching is the whole syllabus is being divided into 9 modules, and these 9 modules are covering, each module covering 2 months, so that by 1.5 years or say 18 months approximately, one rotation of whole of the syllabus is there. Then after that, again the revision starts, and the same modules go on circulating, so that in 3 years' time, one resident, he is subjected with a revision of the whole of the syllabus. And the first one may be regarding the general practices of anesthesia and the pharmacology overall, so that they have an idea what is anesthesia and how we have to be concerned about that. And for then the different systems are there, like respiratory system, cardiovascular system, nervous system. It's like that. Say, suppose in respiratory system, what we do is that for initial 1.5 months, out of these 2 months, the different topics are being taught, and these topics may cover applied physics, applied anatomy, applied physiology, applied pharmacology. And when these are done, then say if I'm talking about respiratory system, then airway assessment, difficult airway, its assessment, then pulmonary function tests, and how these tests are done. Then a patient undergoing anesthesia with respiratory disease and thoracic anesthesia. These are different topics. And super added with these, during this duration, all the equipment which is being used in respiratory system should be covered up, like various, because it's a respiratory system, it's an initial system. So all the supraglottic airway devices, double lumen tubes, bronchial blockers, fiber optic bronchoscope, video laryngoscope, and these are to be taught in a way that the PG should not face any difficulty while describing or using that. So once this, these topics are over, in the last 2 weeks of this first module, say it's a respiratory module, then the various case discussions, case presentations, problem-based learning, and case-based discussions, they are given to the PGs. They may be in the group or in the whole of the class, and different types of scenarios can be created. Here also comes the role of the assessment. So once they have done all these and they know the equipment, they know the theory from knowledge point of view, and they know the pharmacology, physics, everything is there. So now assessment comes. In assessment, MCQs are given as a written exam for, it may be 25 or 30, depending upon the time available. And after that, MCQs, OSCE is given. Now, once OSCE is given, OSCE can vary ranging from equipment description to the consent taking process, communication skills, different soft skills, and everything has to be done in OSCE. Monitoring can be there, and patient's examination can be there. So these are to be done by the faculty, and assessment of the PGs is done this way, and this is the formative sort of assessment. That means the faculty has to tell the PG what they were lacking. So it has to be communicated to them so that they learn it in a better way. And after that, once this is completed, then the final exam, after say all the modules are covered, and after finishing of each module, there is assessment, and then there is a final assessment. So it's a summative sort of assessment. So with these assessments, the students, they have given a very nice feedback that they learned a lot and they could rectify their mistakes. And in all the systems, most of the scenarios are created, whether it's for elective or for emergency or for different techniques. So it's just like that. So it is a bit of, in short, what modular teaching, I consider is going to helpful, because there would be continuity of providing knowledge with the assessment of the PGs, and we know which, because every PG is not, with very high IQ. Okay, there are average also, and we have to help out those. So by this system, with subsequent assessments, we can come to know which PG requires more help, and that way it can be done. Similarly, thesis is also included, and in the initial phase, when the first year comes, first year has to attend a class of research methodology, and that research methodology, it tells everything think because the faculty is from that specialty, they come, they discuss it out with this. So before opting for the thesis topic, they know how to go for that topic, how should we choose, and how should we proceed. And once it's decided with the guide, after 3 months till 6 months, they do it. And when the performer is submitted, after that, regular assessment of the thesis or the protocol, what they are doing, how far they have reached, that is done. 3 months, 6 months, 9 months, and when the thesis is completed, just before that. Logbooks are being maintained, and they write down the interesting cases on few pages also of that rotational specialty where they are posted. So this is, I mean, in every specialty where they go, they have to do this logbook completion. And one more thing which we were not able to do is workplace-based assessment, where the faculty would be assessing the PGs for, I mean, how they are proceeding and what was the behavior of the student PG in the OT with the colleagues, with the faculty, and the teamwork, and inside the OT with the nursing staff. Simulation plays a very good role, and because we had the simulator in our institute, so it helped out a lot, but not many institutes are having simulation. So that doesn't mean that we cannot teach them. There are mannequins available. We can pretend scenarios. By that, because airway mannequins, they are for managing different difficult for laryngoscopy, and airway mannequin for difficult airway. These are available for epidural, for spinal, for skills. These are available, and the faculty has to play a greater role in such modular teaching, because they are equally involved. They have to assess the PGs. And I think with the regular knowledge imparting and assessing and taking their feedback, we may be able to provide more of what they require. I think this I want to convey. So Dr. Radhakrishnan.
Yes, ma'am. Yeah, thank you, madam.
So what should I think from my point of view, I've made it clear to resident.
Thank you. You made it very clear, very crystal clear about the modular teaching and training, which we may have to compel people to adopt the system, which I'm sure with your effort and guidance, well, we may be able to do it in the next 2-3 years' time, known to everybody around, and how to thread further. And well, we had a successful discussion, and all postgraduates who are participating in the process, as well as not participating, we wish you all successful career, and we are there to help you. And whenever you are needing some help, whenever you are falling into some sort of problem, contact any of us. We will be there to push you up. And with that words, I request Dr. Jayashree Sood to make the formal vote of thanks and conclude.
Excuse me, sir. There is one clarification from Dr. Balabhaskar.
Yeah. Please, Anish, please go ahead.
Sir, please, Balabhaskar, sir.
Sir, there is just wanted to add to some of the MD students who would have passed the examinations. There has been this confusion about the DM critical care. So that has been going on since the last 2 years. In 2021, a draft related to the requirements of eligibility to appear in the DM critical care was released by the NMC, then MCA. So one problem that cropped up there was basically with respect to the eligibility criteria and the pattern of questions. Yes, anesthesia, MD anesthesia was students were eligible to take the examinations. So far, the pattern was 60% of the questions would be from critical care or general medicine, mainly general medicine, 60% of the marks. And rest of the 40% would be from some subjects like anesthesia. So that was the way for many, almost for nearly 1.5 decades now. But suddenly this draft, I mentioned that all the questions, 150 questions would be from the broad specialty, general medicine only. So this happened for DM critical care for anesthesia people, and in fact for DM oncology, there is a problem for MD radio oncology also, radiotherapy and radio oncology. So they were expected to answer questions of the broad specialty of general medicine to get a DM onco, and for DM critical care, anesthesia people, we were expected to again answer only the general medicine question. So extremely, there was this opinion that anesthesiologists are deprived of the chances to become critical care specialists, and something like this would remove us from the list of DM critical care. So luckily it went into the Supreme Court. So Supreme Court had, I think, hearing for at least two different times, which happened initially the exam was supposed to be in June. Then both the groups, anesthesia group as well as the onco group, went to the Supreme Court. Supreme Court again issued notices to the National Board as well as which is conducting the exam overall, entrance examination. And again, initially it was supposed to be held on June 18th and 19th. Then the board assured the Supreme Court that no, we are going to come out with fresh eligibility criteria and fresh details in terms of the pattern of examination questions also. Then actually the exams are now supposed to be held on September 1st and 2nd, this entrance examination. But till this point of time, if we go to the website, the board is sticking to its stand, basically that it will be mainly the broad specialty with respect to general medicine only. So at this point of time, I think the situation is not so encouraging to anesthesia. And I think I am right, Dr. Sanish. So this is the feedback I got. We are forced to basically be part of the general medicine group, and they have got an unfair advantage as compared to anesthesia. And this is just like taking away our right in terms of, or we are almost ruled out because they will have an unfair advantage. And in fact, tomorrow, August 25th is the date, then even the admit cards for the entrance examination is going to be released by the board. But I hope the Supreme Court will take cognizance of this and a better sense would prevail. So this is for the information of our immediate MDs who have passed recently and are aspiring to become attend to this program. Best of luck to them also.
Thank you very much, sir.
Thank you.
Thank you very much.
Thank you.
Thank you. Dr. Jayashree Sood?
Yes. Coming to the very special duty of the vote of thanks, it's indeed a pleasure to be proposing this vote of thanks for this very well-planned PG conclave. And let me take the liberty of thanking the students first: Durga, Ramya, Shrad, Rachna, Janish, Azad, Prateek, Anmol, and I may have missed a few. And thank you very much. And your presentations and your thoughts have gone a long way to make us also think of what you feel the education should be, the anesthesia education should be. Thanks a lot. And we wish you all the best in the future. Thank you, Dr. Sainesh and Dr. Radhakrishnan, for actually having planned this PG assembly, this PG conclave, in which it was such a nice thought, and how the students have interacted with us and the seniors have given their words of wisdom. Thanks a lot, Dr. Arvind. That was a very nice, it was a pretty long one, which you really took out time, and thanks a lot for that. Dr. Baljeet, Dr. Balabhaskar, Dr. Anita, and Dr. Balabhaskar, of course, always giving the important insights. Baljeet about the DNB and other postgraduate examinations. Anita, of course, about the modular teaching. Thank you so much. And thanks a lot, Sanish, for always being there with us. And of course, Farhaz was there. Thanks a lot. Dr. Radhakrishnan, thank you so much for conducting this very thoughtful program. And I'm sure the students have all appreciated. I only hope I haven't left out anybody. Thank you very much, and we see you all next week. Thanks a lot. Good night.
Thank you very much, ma'am.
Right.
Good night.
Right.
Good night, everyone.
Good night. Thanks.
Everyone. Thank you all.
Thank you so much.